we're going to do immunodeficiencies. This is not overwhelming. How we use the immune system for testing. And now we're going to talk about disease states. And these are going to range from disease states of the immune system itself all the way through different disease states that we use immunology to detect. Immunodeficiency is, as an inherited or as an infectious disease, is not all that common. It's usually acquired. It's not usually an inherited issue. What we're looking for if we have a child with an inherited immune deficiency disease, we're going to see that they just never get well. They fail, a failure to thrive. What does that mean? What's a failure to thrive? They don't grow right. They are small. They don't show the normal progressive steps that a baby does. You know, as a child develops, it starts to talk, it starts to walk, it starts to crawl. These babies don't grow. They don't start to talk, walk. They don't show facial recognition. They just really don't show any of the hallmarks that a growing child normally does. Early detection and treatment can prevent serious long-term damage if we can catch that they have a problem early on in life. A lot of times it can be managed. It may not be cured, but it can at least be managed. Some of these are not. And we talked about one in hematology, chronic granulomatous disease, where you don't have effective neutrophils, and that leads to death between ages 5 and 6. So some of these are fatal, even if we do find them. Other than an IgA deficiency, primary immunodeficiency syndromes are very rare. You're just not going to see them very often. We do see occasionally a lack of complement in children, but for the most part, the only one that is out there with any kind of numbers is IgA deficiency. And luckily, that's one that we can pretty much overcome pretty quickly and easily. Many show X-linked inheritance, so a lot of times you're going to find them only in boys. And since they are rather rare, a lot of times where you're going to find them is, again, inbred populations. Okay. And that doesn't necessarily mean primitive. There are some religious communities and things like that that don't marry outside of their type, whatever that is. So that's usually, if it gets into that gene pool, that's where we usually start to see a big problem. There's about 120 congenital forms, but again, we just don't see them very, very often. The clinical symptoms range from very mild to pretty much to death in infancy. We have a couple of different types. We have defects in our humoral immunity. This is going to be a problem with our B cells. Did any of you ever see the movie The Boy in the Plastic Bubble? Mm-hmm. That's me. He didn't make any IgG. Basically what you get here is you get recurrent bacterial infections. We don't have any antibody production. You're also going to get viral infections that you just never recover from. Just pretty much constantly sick. Your antibodies do a lot for you. Defects in cell-mediated immunity, we're going to see recurrent viral and fungal infections. Mucocutaneous candidiasis, thrush, is most commonly the one we see here. And this is going to be due to decreased T cell function. We will talk a lot more about this when we talk about HIV, but basically when you're looking at a cell-mediated immunity, you're going to be more susceptible to fungal infections, weird viral infections, cancers, things like that, because that your T cells are not working. Results in defects in phagocytic function. Basically, this is neutrophils that don't work. Or defects in complement. what we're going to see there is a resultant in increase in bacterial infections because your complement cascade can't kill the bacteria. And that is the most effective means of killing bacteria is complement. If you can't fix complement, your cytotoxic cells don't do quite as good a job as does the complement itself. Okay? That's our most effective weapon against bacteria. Bruton's A gamma globulinemia means I don't have any gamma globulin, which is what?
Antibodies.
IgG. Means I don't have any IgG. It is sex-linked. It's due to a lack of circulating B cells. You have a deficiency of all classes of immunoglobulins. You don't have plasma cells. My T cells are normal though. We can give IV or shots of immunoglobulins and antibiotics, but this is a deficiency in B cells or humoral immunity. Pretty much all of these are zebras. Okay? All of these are zebras, these inherited ones. Acquired immunodeficiency is not a zebra, but the inherited immunodeficiencies are all zebras. IgA deficiency is the most common congenital immunodeficiency, but it is by no means common. It's not out there enough. Most patients are totally asymptomatic. We find it accidentally. You will see a slight increase in respiratory and GI infections simply because you do secrete IgA into your nasal, into the mucus and in your throat, so that when you're eating and breathing things in, that IgA kind of combines with the antigens and kind of wipes them out before they really get going. We do see an increased risk of autoimmune disease, and I don't actually know the mechanism for that, partially because autoimmune disease isn't as well understood as we would like it to be anyway. We can give gamma globulin. It does have some IgA in it, but you can develop antibodies to IgA if we give you somebody else's or manufactured IgA. It is again a B cell deficiency or a humoral immunity deficiency. But like I said, most patients are asymptomatic, don't really require treatment. So the most common zebra doesn't usually need anything to be done with it anyway. Yes? Obviously the gamma globulin they give must be a combination of, I thought it was IgG too. So it's obviously must be a mix of immunoglobulins. I thought it was straight IgG. The DeGeorge anomaly, obviously there's going to be a test question on at least one of these, but this is not where I would spend the bulk of my study time. This is a persistent T cell problem. Okay. Again, you're going to have recurrent viral and fungal infections. You treat with a fetal thymus transplant. That's nice. Okay. But it is a T cell deficiency. The biggest question I'm looking at these probably being is which are B cell, which are T cell. Not going to spend a lot of time on zebra questions. Severe combined immunodeficiency. Oh, damn. That's pretty much what this is. It's a bunch of different diseases. They're not specified out because they don't have enough cases of any one to really study them in depth. So they just sort of lump them into, this is severe combined immunodeficiency is sort of it's a group of related diseases that can affect T and or B cell function. X-linked is most common. Again, it affects the interleukin receptors, so the cells can't talk to each other. There's a group of these where basically what happens is they can't talk to each other. And that's essential. If they can't talk to each other, if the CD4 cell can't talk to the B cell and tell it to make antibodies, you got a problem. If the B cell, or if the CD suppressor cell can't make a memory cell, you're going to have problems. Okay? You're going to see a lot of infections in infancy, just never going to get better. Basically, you can try a bone marrow transplantation. Again, this is such a rare thing to say, well, you know, I had 100 cases and 10 of them responded to bone marrow transplantation, 5 of them didn't, and I didn't treat the other ones. It doesn't give us enough numbers to really give us any kind of accurate data, but pretty much any kind of combined immunodeficiency is going to lead to death in infancy or by the time they're 2 at the latest. Luckily, these are uber super rare. This is the one we talked about in hematology, chronic granulomatous disease. It is autosomal. Basically what happens is that the granules of your neutrophils don't have these cytotoxic chemicals that they're supposed to. You're going to see recurrent infections, especially with normal flora, staph and strep, E. coli. You're going to treat with antibiotics to prevent severe infections. You could try granulocyte transfusions or bone marrow transplant. That's about your only options for it. Once again, usually death by age 6 if it is untreated. We don't have enough numbers that I don't know if bone marrow transplant is always successful or not. How do we test for immunodeficiencies? Well, the first place we're going to start is our basic CBC. We're going to look at your white count. Okay. If you're showing symptoms of immunodeficiency, in other words, recurrent infections or incomplete recovery from infections, what we're going to do, we're always going to start with the simple stuff first. You know, don't jump to the, don't look for zebras, look for horses. Maybe you have a low white count. Or maybe we can find something in your CBC. That's cheap, that's easy, that's quick. We can measure directly your serum globulin levels. I can do a quantitative IgG, IgA, IgM. Yes?
Would you expect the white blood cell count to be elevated because of the recurrent infections or decreased because of the lack of
Usually what's going to happen is your white count is going to be either increased because your white cells are trying to fight off the infections that the rest of your immune system can't handle. Your neutrophils are going to be having to do double duty. Or you're going to see it normal because that's not the problem. Okay. Cell-mediated, we're going to do a delayed hypersensitivity skin test. We're going to do a chest x-ray to look at your thymus and see if it's normal sized or not. Any kind of neutrophilic, there is an NBT test, which is a neutrophilic function test. Decreased if color doesn't turn blue. Well, basically what you do is you throw neutrophils in there with something. You put a marker that if it releases the if it releases the hydrogen peroxide or releases the peroxidases, it will turn our indicator blue. So if it doesn't turn the indicator blue, you're missing the cytochemicals, yes?
If your white blood count is elevated and you do a dip, are you going to see immatures because you have to spit it out so quickly to use them for your infection?
Depends on how well your bone marrow has accommodated. If you are having an increased neutrophil count all the time, you won't see immatures. When you see the immatures is when you have an acute condition, because you keep a supply of mature cells. So the only time the immature ones have to come out is when the grown-ups can't take care of things and they got to get the teenagers to give them a hand. Okay, so you won't necessarily see that left shift, because if you're always needing more neutrophils, you're going to up your production of granulocytes constantly. So you probably
on onset, but not once it's
yeah. As you progress, you're just going to have a persistently elevated neutrophil count. Complement we can measure. We can do a CH50 or a C3, C4 level. We can do a protein electrophoresis to look for a decrease in the gamma region. Hint, it's a lot easier to do this than this, because most of the time for urine protein electrophoresis, we really want a 24-hour urine, and people screw up the collection of that a lot more than they do anything else, and this is a simple blood draw and I can get it done today. This has to go to electrophoresis, and that may take a couple days. So this is pretty straightforward. Throw it on a chemistry analyzer, push the button, spits out an answer. Confirmatory tests. Basically, we're going to do B cell count. And how am I going to count B cells? I'm going to put them under the scope and go 1, 2, 3, 4, 5. How am I going to count B cells?
Add an antibody or a virus?
What?
Add a virus? So
Nope.
it creates antibodies?
Nope. Oh, y'all really need to start putting this stuff all together. How do I identify a B cell? They're lymphs, but how do I identify a B cell?
Are they the reactive ones?
No. How do I identify a B cell? Oh, you are going to feel so stupid when you come up with the answer. How do I identify a B cell? Do these initials mean anything to you? I told you you'd all feel stupid when you figured it out. We're going to measure the CD markers. We're going to send them through a flow cell cytometer. No, Diane, you're not supposed to make us think. What's that? Y'all got to start putting this stuff together. It all intertwines. It gets worse, okay? Actually, blood bank and micro are kind of almost their own beasties. It's the heme, the chemistry, the serology, and UA body fluids. This semester is the stuff that really, really hits together. Okay. Cell mediated, we're going to do T cell counts. How are we going to do T cell counts? Yeah, I said, I told you as soon as I said, and I understand. I have been in your seat. What the hell is she asking? Oh, yeah, I knew that. So phagocytic or neutrophil defect. I'm just making sure you're on the way. That's all I was doing. I can do. There's a variety of different chemotaxis assays I can do. I can do a leukocyte adhesion, phagocytosis assays. Pretty much anymore, what we do is we can just directly measure for the myeloperoxidase. We can just do a myeloperoxidase measure. Complement, again, I can do specific complement assays. IFE, immunofixation, is going to show me just what kind of immunoglobulins I've got. Like I said, really, electrophoresis is not the best method to do that. Now, it is the best method if I'm looking for multiple myeloma or Waldenstrom's, because it will be positive early on. So that was not going to have a ton of stuff question-wise. Let's get through one more. And we'll have lunch.
Lunch on Friday.
Oh, you don't have lunch on Friday. You guys leave at noon on Friday.
Yep.
Yeah.
Oh, I don't have to give you lunch. But I will give you a break. I don't know what day of the week it is. I still feel like it's been Monday. All right. So we talked about the immunodeficiencies. Now, I'm not going to take it personally when you don't remember anything, because we've already talked about all of this. Okay? But I'm not going to take it personally because that was like months ago. And I have to review it every year when I talk about it too. So we're basically, most of our immunoproliferative diseases are going to involve B cells, although not all of them. Basically, if you remember, we had an entire couple of PowerPoints on lymphoproliferative diseases, and it listed like a gazillion of them. Okay? So we're just going to kind of hit them on the highlights, a couple of the big ones. Review here. What's the difference between leukemia and lymphoma? Where it originates. Leukemias originate in the bone marrow. Lymphomas originate in the extramedullary tissues. Okay, in other words, outside the bone marrow. That's the difference between leukemia and lymphoma. And they can turn into each other. Most commonly, lymphoma becomes leukemia. plasma cell dyscrasias, basically we're going to look at multiple myeloma and Waldenstrom's macroglobulinemia. We talked about these last. Not classified as either leukemias or lymphomas. That's in the old classification system. They actually have been they have now been classified. The WHO classification system that we use. Remember that? The WHO? The WHO? Yeah, the WHO. Okay. They are classified as a lymphoma or a leukemia based on where they originate. They show a monoclonal gammopathy, an overproduction of a single immunoglobulin component. Okay. It's a paraprotein. So basically when I do my electrophoresis, I'm going to get a bump. I'm going to get a big bump. Generally in multiple myeloma, we are dealing with IgG, generally. We can get an IG. I have seen multiple myeloma with an IgA. And Waldenstrom's macroglobulinemia, we are always dealing with IgM. That's why it's called macroglobulinemia, because what's the biggest immunoglobulin? M, because it's a pentamer. Okay, so that's why it's macroglobulinemia, is because we're dealing with this pentamer. Multiple myeloma is the most serious, and it really is the most common. Many people that we find have it, we find it by accident, frequently from broken bones. If you remember, we had x-ray pictures of multiple myeloma, and it showed that it basically looks, your bones start looking like Swiss cheese as the plasma cells just sort of dig in and eat out and eat through the bone. It originates generally in the bone marrow. It can move into the non-red marrow. In other words, it's where's most of your blood production occur in an adult? The flat bones and the ends of the long bones. It can actually move its way through the yellow marrow sections as well to where it's not normally producing. So it can move from the ends of the long bones down in through the rest of it. But it can be very insidious. In other words, you might have it for a long time before you actually know you have it. So you could have a really whopping case of it before it's located, before you find it. Okay. Most commonly we find it in older people between 40 and 70 years of age. If you make it to 70, I guess you're okay. But it is found in later middle age, early old age. It affects blacks more than whites and males more than females. So if you're a black male, you really are, you're doomed. Basically what happens is I have plasma cells that take over the bone marrow. And you proliferate nothing but plasma cells. Our first sign is often a monoclonal gammopathy. When we do an electrophoresis, we're going to see a spike in the G region of the electrophoresis. And when we do an IFE, we'll generally have a monoclonal gammopathy, which means I'm going to have a single spike at one of the immunoglobulin levels. Okay? And they are clonal. Okay? This is not like a leukemia where you're producing new ones. These are clonal. This is one B cell that runs amok and clones itself way too much and starts producing antibody. We will see MOT cells in the bone marrow occasionally because these guys are really, really cranking it out there. We see lytic bone lesions, often involving the spine or the chest. Why? Well, because the chest is all flat bones, and there's bone marrow, there's red marrow in all of those spaces. And there is also marrow production going on in some of the flat bones in your spine. You can develop acute or chronic renal failure. All right, well, you've been seeing it all comes together, don't it? What happens if you have too much protein? What does that do? What does it stress? It stresses your kidneys. So what you're going to see here, you're going to start seeing protein in the urine. In this case, it isn't the kidneys going bad that makes the protein, it's the excess protein that makes the kidneys go bad. Okay? It overdoes the kidneys because protein is huge. proteins are very, very molecularly large molecules. And so they shouldn't be going through the glomerulus. But if you have an inflammation of the glomerulus, or glomerular nephritis, you're going to see protein spill out, right? Well, what happens in this case is you have so much protein, it pretty much forces its way through the glomerulus, which causes the inflammation to begin with. So it really is a wicked cycle that the high protein puts pressure on the glomerulus. The molecules force themselves through, which cause inflammation in the glomerulus, which allows protein to escape. So it can lead to acute renal failure. You're going to see an increase in abnormal immunoglobulins. You're going to see a high incidence of infection. Well, I got lots of immunoglobulin. Why am I getting infections? Because it's not working. You make lots of it, but it's crap. It just doesn't do anything. Okay? So it doesn't matter if you got tons of it, it's not going to do anything. Most commonly we see IgG, but I have seen IgA, and you can have a multiple myeloma that's IgM, but most of the time increased IgM production is associated with Waldenstrom instead. You're going to see free light chains in the urine. You're going to see anemia, thrombocytopenia, and neutropenia. Why? Why am I going to see anemia? What the heck? Immunoglobulins don't have anything to do with anemia. Why am I going to see anemia?
So you're using the resources to make your mature?
Because the bone marrow resources are being used up to make the plasma cells instead of doing what they're supposed to do. Okay? It's the same reason we see these decreases in pretty much any kind of leukemia, is that the bone marrow resources are being used for other cell types. We're going to see high levels of these M protein, and that can lead to thrombotic conditions. Anytime I have a high protein, I can see rouleau on my CDC slide. And what does rouleau look like?
Stacks.
Coin stacks of red cells. We didn't get to it this year, but I have one of absolutely the ugliest slides ever on the face of the earth. This lady's leukemia was awful. The cells don't look like anything they should look like, and she has so much rouleau that it almost looks like she has fence bars in her on her diff. You can visibly, macroscopically see that when you slide it out, you can almost see the red cells stacking up and agglutinating together. It was, just getting a slide you could even read was a major problem. And her problem was multiple myeloma.
We saw one too, and it was like pancakes. It was like,
Would you see them, like, if you're counting body fluids on?
Oh, absolutely, yeah.
I saw a bunch of those.
Now, on the body fluid slides, because those are cytospins, and we're concentrating those, when we do a regular diff slide, we smear them out. So sometimes it's an artifact of the slide making process on that one. But yeah, you will see they will kind of stack up together. My favorite one, and this was before the days of cell phones when you could take pictures, we had a urine that had a really high protein and lots of red cells, and you literally could watch it under the scope. You'd put it in there, and all the red cells would you could just watch them all float together and make these lovely coin stacks. It was rather entertaining. It was a slow night. We're going to see hyperviscosity of the serum because we've got so much protein in there. These paraproteins are most often going to be seen with excessive IgM. Why? Because IgM is so dang big. You're going to see bone pain because the multiple myeloma is eating through your bones. Okay, and I would think that would hurt. If you're putting holes in your bones, I'm thinking that's going to be painful. I'm going to see hypercalcemia. Okay, first of all, what's hypercalcemia? Increased calcium. Why am I gonna see an increased calcium in the blood?
Bones break down.
What's that?
Bones breaking down.
Because your bones are breaking down and it's releasing all that calcium. What can that do to you? What does hypercalcemia lead to? Pardon?
No, that's decreased calcium.
Is that hypo?
I think it's hypo.
I don't know. I haven't studied chemistry in eons. You guys just got done with it. Also, you could help me out here. I know calcium affects the
Oh,
heart.
kidney stones.
It can lead to kidney stones. That one I know. I know urine and I know blood and I know heme. Don't know calcium. I'll look it up. No, y'all look it up. How are we going to diagnose it? We're going to do a bone marrow biopsy and we're going to see more than 10% plasma cells in the bone marrow. Do we see plasma cells in the peripheral blood?
Yes.
Yes. There's one yes. There's 9 more or 11 more of you.
That's a yes.
We got 2 yeses. Plasma cells in peripheral blood. I got 2 yeses, waiting for the rest of you.
Usually your plasma
Yeah,
cells
I
are
see
normal
no.
or
Normal or no?
immunoglobulins. They have to.
No. We call them plasmacytoid lymphocytes. We do not call them plasma cells unless they're in the bone marrow. And yes, if you get enough of them circulating from the bone marrow, they can leak into circulation. However, we won't call them plasma cells if they are only in the blood. You have to find them in the bone marrow in order to actually call it plasma cells. Now, if they then come out into, if you've already diagnosed it, that they're in the blood, in the bone marrow, and they come out into the peripheral blood, then we will call them. But you do not call plasma cells based only on peripheral blood. It has to come based on bone marrow biopsy. Yes.
So the plasma cells are what create the IgGs.
Yeah.
The IgGs released from the bone and into circulation in the bone, and then that's where they start to travel from.
Yeah, it eats its way out of there. Waldenstrom's. The difference between Waldenstrom's and multiple myeloma, in multiple myeloma, the B cells grow up, turn into plasma cells, just like they're supposed to. In Waldenstrom's, well, frankly, we've got some misbehaving young men and women here. The malignant cells are not all the way to the plasma cell stage. They're somewhere between an undifferentiated lymphocyte and a plasma cell. They don't have the typical windswept appearance. You will not see them as Mott cells. You will not see the immunoglobulins built up in the cytoplasm. And they just don't look like a plasma cell. They will infiltrate the bone marrow, the spleen, and the lymph nodes. So Waldenstrom's macroglobulinemia is more to a lymphoma, but it can be either leukemia or a lymphoma. But it tends to affect the extramedullary lymphoid tissue more than just the bone marrow. Multiple myeloma stays pretty much in the bone marrow until the very end stages. Whereas in Waldenstrom's, these cells they're not as picky about where they live. They'll head out into the spleen, the lymph nodes, and the other lymphoid tissue. You're going to see a malignant proliferation of IgM producing lymphocytes. You're going to see a lot of kappa light chains. When you're doing your immunoelectrophoresis, that little bump that is the kappa and lambda chains, the kappa is going to be quite large. The median age is 65. Okay. Older adults. Not as common as multiple myeloma. I've seen a couple cases of this. Again, it really isn't as common. Multiple myeloma, I've seen lots of cases of that. They can act as a cryoglobulin. And basically what happens there, IgM is a cold reacting antibody. And that's very important when you hit blood bank. IgM is cold, IgG is warm. IgM is cold, IgG is warm. It's very important because we administer blood when it's warm. So if you have an IgM antibody, it might be okay. All right, IgG ones are the important ones. So IgM, what it can do if it gets to be in high enough dosages, it can act as a cryoglobulin, which means when it gets cold, it's going to precipitate out. Where is it going to get cold in your body most?
Extremities.
It's your tip of your nose, the edge of your ears, your fingers, your toes, okay? And what can happen is you can get necrosis occurring at the extremities if the patient gets cold.
So it's like self-induced, what's it called, snow?
Frostbite.
Yeah. It's like
Yeah.
self-induced frostbite then?
Pretty much, yes. Basically what happens if you get, and it doesn't have to be super cold, just, you know, below room temperature, because if it gets cold, what does your body do? When it gets cold, what does your body do?
Pulls your blood towards the
It pulls all your blood towards the core, okay? Which means you have less blood circulating in your fingers, which is why when it's cold, your fingers get cold and your toes get cold, you know. And when they tell you, well, you can just put on a sweater, yeah, but that doesn't help when the end of your nose is cold, right? Okay. So, but it pulls the blood into your core. So what happens is, as it gets colder, these cryoglobulins, or this IgM molecule, actually precipitates out as a gel. And that blocks the blood vessels. And what happens when you block the blood vessels to tissue? The tissue dies. So you wind up with frostbite, essentially. It's exactly what it looks like. You have dead tissue at the extremities because you didn't have the circulation. It will also produce a cold hemolytic anemia, cold autoimmune hemolytic anemia, and it's a nasty one to have to mess with. It is hard to get it to go away. You can wash these cells like 1 billion times and you'll still have problems with this thing. But the reactions will be at room temperature and colder most of the time. If you have a really severe one, it'll go on to Coombs, but for the most part, you're looking at cold. You're going to see weakness and fatigue. You're going to see anemia and bleeding. Why am I going to see bleeding? Because I'm going to be losing platelets. Okay. Hyperviscosity. The blood on these people literally, like when you drip it, and again, it comes in varying degrees, but if you get someone who's got a really bad case of it, which is the only one I've ever seen, you literally could take their blood, pull it, their plasma, and pull it up in a transfer pipette, and instead of going drip, 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 it kind of went ooze, blop, ooze, blop. I mean, you could, it just was slimy. It was nasty. I was like, the only thing we could think of was, yeah, but the joints will be real lubricated. About 10 to 20% have paraproteins that behave as cryoglobulins. I don't know why it repeated that, but yeah. So these paraproteins are of actin. You do not see Vence-Jones. You are not going to see kappa and lambda light chains. You will not see the lytic bone lesions. The Waldenstrom cells do not eat through the bone like the plasma cells do. You are not going to see the hypercalcemia. And says you won't see the renal tubular abnormalities. The only problem here is sometimes the blood is so viscous going through that it causes inflammation, just because the blood is so viscous going through the kidneys that it dilates the blood vessels. Okay. It also can cause hypertension, just because it's a lot harder for your heart to pump sludge than it is to pump liquid. How do we evaluate them? Well, first of all, we're going to do flow cell, and we're going to look for abnormalities. We're going to look for plasma cell markers. We're going to do immunophenotyping to identify what type of cells we have. And most commonly, with our multiple myeloma, we're going to be looking for B cells. We're going to do immunoglobulins. We can either measure serum immunoglobulins, and basically here they're just talking about electrophoresis. But remember, there are now assays out there that we can just directly measure how much IgG, IgM, and IgA you have. We can also measure your IgE if we want to. I guess we can measure IgD, but But our serum protein electrophoresis and our immunoelectrophoresis, immunofixation, we're gonna look 70 to 80% light chains, 70 to 80% of your light chains are gonna be kappa. Not a ton of information there, but something.